This conference will now be recorded.
Hi, everyone. Welcome to week 6 of your N211 class. So there's only 1 week left. All right. So you guys have 1 week left of class with me. Today, we're going to be continuing from week 5 on abnormal cellular growth. So make sure you guys do your reading in your ebook. And also, today's PowerPoints are going to be these 3 that are up here: week 6 medication, screening methods, and then leukemia. And then there's the extra week 6 PowerPoint. That's just for extra notes, and it's just for like extra resources for you to review. So you may see some things that we talk about in class. There may be some other things in there as well, other information, but please utilize it if you need to. But of course, the notes that we go over from today's class will be these 3 PowerPoints up here. And I will highlight a few important things that you need to know, but I do expect that you do your reading. I do expect also that you take a look at some of these videos. I found a bunch of different videos here for you. Just about the topics we're going to be covering today, and even some extra topics just for further information. So take a look at them. Some are a little bit longer than others, but it's up to you. If you need the extra resources, please utilize them. There's also quizzes here for you. Of course, if there's any questions or comments, please email me or send me a message here and let me know, okay? So I won't keep you guys too long today. I'm just gonna go over, like I said, basic information, what you need to know, just to finish up week 6. For next week, which is week 7, like I said to you guys numerous times, it is not any new information next week. Week 7 is just gonna be a cumulative recap of the previous 6 weeks. So in the event we get out a little bit early today or a little bit earlier next week, please use that time to go back and review your previous weeks. I know week 1 was very heavy, a lot of cardiac information in there, so go back and review it. Even the respiratory pulmonary section, go back and review it as well, and make sure that you feel prepared enough for your exam. I hope that you guys are thinking about when you want to take your test and take your exam so that you can be, you can be ready for it. And you have 3 weeks once this class is over with. So please utilize everything that's available for you, the quizzes, everything on the learning platform, all of your extra resources, extra PowerPoints, review PowerPoints, all the links that are on there, the videos. It's all there to help you guys so that you're going to be successful when you take your exam. Okay, and of course you need to email me and let me know how you did, and also academics, how you did on your exam. So John just arrived. Hi, John. So we're gonna start with abnormal cellular growth. And like I said, this is just a continuation of from last week. So we're going to talk today about the types of leukemias, sarcomas, Hodgkin's and non-Hodgkin's, and then multiple myeloma. So the information we're going over today is going to be, very general information, basic information, what you need to know. You can read more or look at the videos that, like I said, that I posted for you. But you're going to start to see when you're looking at the different types of leukemia, sarcomas, I want you to see what makes them all similar. So what do they all have in common, and then what makes them different? That's the best way for you guys to really, understand the information. Let me move this over a little bit. Here we go. To understand the information and also understand what makes these different symptoms, signs and symptoms. Are they similar? What do they have in common? And what is the hallmark sign and symptom for the different illnesses? So for the first one with leukemia, it is a cancer of the body's blood-forming tissues. That's what leukemia is. And if you think of leukemia, think of leukocytes. We think about leukocytes as your white blood cells. So go back into your A&P and think about leukemia and leukocytes, and it's the blood-forming tissues, including bone marrow, including lymphatic system. So I want you guys to think about blood. Think about with leukemia, there's different types that exist. There's some forms that are more common in children, and there's other forms that are most common in adults. So leukemias involve your white blood cell. Like I said, leuko meaning white. So your white blood cells, and the white blood cells, we know, what do? They fight infection. So those are your army. Those are your fighters. So they normally will grow and they divide very orderly, right? Your body's set up in a way where things are organized and orderly, and they develop as your body needs them. But for people that have leukemia, the bone marrow, which produces all the blood cells, the bone marrow produces abnormal white blood cells, right? And these white blood cells, because they're abnormal, they don't function very well. So the treatment for leukemia is going to be complex. It depends on the type of leukemia, the factors associated with the leukemia. You know, there's strategies and resources to make treatment successful. I'm sure you guys see commercials all the time for cancer treatment centers and what can you do to help, but we have to figure out the type of leukemia, the factors that surround it, and what needs to happen to, you know, as treatment, palliative care, how can we help this patient that has leukemia? What type of leukemia do they have? So the basic thing I want you guys to understand about leukemia is it occurs in children and adults. It's a cancer of the body's blood-forming tissues. It involves your white blood cells. And think about what the bone marrow does, but the bone marrow in this case produces abnormal white blood cells that do not function properly. Okay, that's the problem. So leukemia symptoms are going to vary based on the type of leukemia we're dealing with. So common leukemia signs and symptoms, these are going to be the common ones, okay? Take a look at these, make sure you're familiar with them. Fever or chills, fatigue and weakness, severe infections, losing weight, they're not trying, but they're losing weight, swollen lymph nodes, enlarged liver or spleen. Think about your lymphatic system, think about your immune system. So far, some of this stuff sounds like if you had a flu, right? Fever, chills, weakness, infection, the swollen lymph nodes or your glands are swollen. So think about what's happening in the body. It's not far-fetched. Easy bleeding or bruising, now that's a little bit different than having a flu. Recurrent nosebleeds, a little bit different than having a flu. Even the red spots, the petechiae, the sweating, especially at night, bone pain or tenderness. So there's some that sound like flu-like symptoms, so you may not go to get them checked out, or tell you the patient might not go to get them checked out. When the bleeding starts to happen, the spots they start to get, they're sweating a lot at night, the bone pain and tenderness, that might trigger them to go and see what's happening with them. So these are the common signs and symptoms. But in general, leukemia is thought to occur when blood cells acquire mutations in their DNA, okay? You don't have to learn all about that, but just understand that DNA is what allows the cells to be developed in a specific way. These are the instructions inside the cell. That's a good way of putting it. It's the instructions. But there's other changes in the cell that has to be understood that could contribute as well to the leukemia. So some abnormalities cause the cells to grow and divide more rapidly, and they continue to live when they should die. So there's a specific time frame of when they should live, what they do, and when they die. So abnormalities cause all that stuff to be messed up. They might divide rapidly, they might be abnormal, they might live too long. So they crowd out all the healthy blood cells, and that's what happens. So that's what it says. So these abnormal cells, they're going to crowd out all the good ones in the bone marrow, leading to fewer healthier white blood cells. And you know what the white blood cells are for your immune system, for your protection. They fight off. They're your defenders. So in the bone marrow, it leads to fewer white blood cells, red blood cells, and platelets. These are going to cause the signs and symptoms of leukemia. So keep it in the back of your mind. And if you're doing notes, guys, on leukemia, the way I would say, and this is just for me, I would just put leukemia in a box like this. And then, like I said, do a little concept map. Draw a few arrows that come off of leukemia. Write down WBC. When you think of WBC, think of infection, think of defender. Whatever you have to do to cause you to remember, signs and symptoms are going to be flu-like along with other things. So write about the other things that are included. So what happens with leukemia? Think about what's happening with the red blood cells, the white blood cells. The bone marrow is not working properly. It's affecting the DNA. There's mutations happening. So think of all these different things when you get a question on leukemia. All of this should be going on in your head. What I tell students to do when they get a question, don't look at the answers. Even when you guys are practicing, read the question and put like a piece of paper over the answers. What I want you to start doing is start doing like a strategy discussion in your head. If you see leukemia, cover the answers and start to think about all the things that surround leukemia. How does it happen? what causes, the issue, what are the signs and symptoms, what do we do about it, how are they classified, for example. So all of this should be going on in your mind. So when you see the answers now, it's not like it's the first time you're understanding about leukemia, and the answers are not blinding your thought process. You're not even looking at the answers. That starts to make you think, oh, that answer looks right, or that answer looks wrong. That's not how you pass an exam for nursing, right? It's got to make sense. So that's just a strategy that I tell my NCLEX students all the time. When you see the question, just don't look at the answers. Think to yourself, what is it asking? Are they looking for something that is that needs more, requires more teaching, something that the patient understands the teaching, whatever it might be. So you're looking for something right or something wrong. Are we assessing or are we implementing? This is the way I want you guys to approach your questions, because that's how nursing is. It's not about reading a question and just that answer looks right. Then then anybody can be a nurse, right? So that's just a little side note. So leukemia classification, the first type of classification is about how fast that leukemia is going to progress. So we have acute leukemia. So in acute leukemia, the abnormal blood cells are the immature blood cells. They're called blasts, okay? They do not carry out normal function. They multiply very rapidly, so the disease worsens quickly. Think of it as acute. Acute leukemia requires aggressive and timely treatment. It's acute, it's fast, it's happening right now. Chronic leukemia, there's many types. So some produce too many cells, some cause too fewer cells to be produced. So two things are happening, too many or too few. So chronic leukemia involves more of the mature blood cells. Acute involves the blasts, which we know are immature. These are the mature, chronic. So these blood cells are going to replicate or accumulate slowly, and they function normally over a period of time. So some forms of this chronic leukemia is going to initially produce either no symptoms, and they can go unnoticed for years before they're diagnosed. Not acute, it's happening right now. Okay, just think of what the words mean. Did I skip a slide? Okay, so the second type, here we go. The second type classification is by the type of white blood cells that are affected. So we have lymphocytic, we have myelogenous. So lymphocytic leukemia affects your lymphoid cells or your lymphocytes. And do not get thrown off by words. All I need you guys to do is break up the words. Cytes meaning cells, lymph meaning like the lymphatic system. So break them up, that way it's easier for you to understand what they mean. Okay, the words are just long for the sake of being long, but just make sure you understand what the words mean. So they affect the lymphocytes, which form lymphoid or lymphatic tissue. It's all the same thing. Lymphatic tissue is what makes up your immune system, which goes back to leukemia, right? What does leukemia affect? Myelogenous affect your myeloid cells. These are the ones that give rise or create the red blood cells. So the white blood cells and the platelet producing cells. So this is where myeloid comes from. The myeloid cells, they give rise to one red blood cell, white blood cell, and platelet producing cells. So this leukemia affects the myeloid cells. So it's going to affect how the red blood cells, white blood cells, and platelet producing cells are going to be born, or they're going to produce. Okay, that gives rise to that. The major types of leukemia. I need you guys to review this slide. Just review it. I'm not saying that you have to know every single detail about all the different types of leukemia. See, the first one is all the different types of leukemia. I do go into a little bit of explanation and a little bit of detail, but and it's in your reading as well. But just understand basically what I have on this slide here. So we have the ALL, which is acute lymphocytic leukemia. It's the most common type in young children, also in adults. Acute myelogenous leukemia, AML, common type of leukemia, occurs in children and adults again. It's the most common type of acute leukemia in adults, okay? Chronic lymphocytic leukemia, CLL, most common chronic adult leukemia. They may feel well without needing treatment for years, okay? Chronic myelogenous leukemia, CML, affects adults mainly, but a person that has it may have few or no symptoms for months or years. See the words right here, guys. Chronic, acute. That should tell you right away, are they having symptoms right now? Or can they live with it for a while? And then other rare types of leukemias exist. We have hairy cell leukemia, myelodysplastic syndrome, and myeloproliferative disorders. So just be aware that they exist. I don't believe your questions are going to be so basic where they ask you what is the most common type of leukemia. That's a low-level thinking question. That's just literally memorizing which one it is. I want you guys to have an idea about what the leukemias are, and factors, for example, that increase the risk. So let's talk about that. And then I think I have some slides that just talk about the signs and symptoms and risk factors for the different types of leukemia. So we have factors that may increase the risk of developing some types of leukemia if they have had previous cancer treatment. So patients that have had chemo, radiation, or some type of cancer therapy, they are at an increased risk for developing certain types of leukemia. Genetic disorders, so some type of abnormality is going to increase the risk. So maybe Down syndrome, they're going to have an increased risk of leukemia. Exposure to chemicals, so some chemicals, benzene, which is found in gasoline, in the chemical industry, is linked to some types of leukemia. Smoking causes everything. So smoking cigarettes increases the risk of AML. And then a family history, of course, your genetics plays a big part in everything. So family history of leukemia, if family members have been diagnosed, then having the disease, the risk for that is going to be increased. So having an idea about the risk factors is important. It helps when we're doing an H&P on the patient and we're able to identify, do you have a family history of this? Have you ever had chemo? Do you smoke? You're asking all these questions because you're trying to understand, is that contributing to them having the leukemia? So some diagnostic exams, doctors may find leukemia in a routine blood test even before symptoms start. If this happens, or if the signs and symptoms suggest leukemia, they're going to undergo some diagnostic exams. So the first thing is a physical. They're going to look for signs of leukemia. So pale skin, maybe they have some anemia, the lymph nodes are swollen, the spleen and liver are enlarged, because think about white blood cells, think about the area that they're going to be affecting. So that's why you're going to have a large enlargement of liver and spleen. Blood tests they're gonna do a sample. They're gonna look at abnormal levels of red or white blood cells or platelets, which could also indicate leukemia. Bone marrow testing. So they're gonna remove a sample from the hip. They use a long needle. They get in there. They pull out the marrow. And specialized tests for leukemia are gonna reveal characteristics that determine the treatment at that point if they have it. So some common treatments for leukemia, and you guys know this is just a review. We have the chemo, which is a main form or major form of treatment for leukemia, where the drug is going to kill the leukemia cells and often other cells that are also good. Depending on the type of leukemia, the patients might have a single drug or a combination of drugs. We're going to talk about meds at the end of today's lecture. So the drugs could be pills, it could be directly injected to a vein. It just depends what the patient's needs are. Biological therapy, this is where they use biologics to use as treatments to help the immune system recognize and attack those cells. So you're trying to get rid of them from the inside out. And then targeted therapy, this is where they use drugs to attack specific vulnerabilities in those cancer cells. So for example, they have Gleevec, which stops the protein within the leukemia cells from people that have CML. It helps to control the disease. So the drugs work in different ways, very similar to HIV medications, where it stops the transmission in different stages. This is what targeted therapy is. It's going to get the specific vulnerability and attack it in the cancer. So we also have radiation therapy, which is where they use X-rays or high energy beams to damage leukemia cells and stop them from growing. So patients may sometimes receive radiation in one specific area where there's a lot of these leukemia cells, or radiation over the entire body. So radiation therapy is sometimes used to prepare for stem cell transplant. Okay, so you're getting rid of all the bad cells before you actually give them the stem cell. So the stem cell transplant is a procedure to replace diseased bone marrow with healthy bone marrow. okay? Before they do a stem cell transplant, they get a very high dose of chemo or radiation. That's going to destroy the diseased bone, so that way when they put the good stem cells in, it's going to help to rebuild the bone marrow, okay? Makes sense. So patients going to receive from a donor or even their own stem cells. It's very similar to having a bone marrow transplant. They just transplant the stem cells instead. So a little bit on ALL, and it's not a lot. I just have information for you guys, just basic. That's really what today's lecture is going to be, the different types. So ALL is a type of cancer of the blood and bone marrow. It's spongy tissue, which is inside the bones where the blood cells are made. You guys already know what that is. So the word acute comes from the fact that the disease progresses rapidly. It creates immature blood cells, not mature ones, and then lymphocytic in acute lymphocytic leukemia means the white blood cells called lymphocytes, which is what all affects. That's what this leukemia affects. So it's also known as acute lymphoblastic leukemia, ALL. So ALL is the most common type of cancer in children, and the treatment results in a good chance for cure. It also can happen in adults, but the chance of cure is reduced for adults. Some signs and symptoms, I'm going to say again, review these signs and symptoms for ALL, for acute lymphocytic leukemia. We get the bleeding from the gums, bone pain, fever. They get a lot of infections, frequent nosebleeds. The lymph glands are swollen. They have pale skin, shortness of breath, and weakness. Okay, that's the main symptoms. And you'll notice as we go through some of these different types, the symptoms are going to be similar, so you don't have to memorize every single symptom. What I want you to focus on are the ones that may be a little bit different for each one, but they're usually pretty much the same. So the risk factors for all, and this up here, guys, just explains what occurs when there's an error in the DNA. It's pretty much the same for each one we're talking about. I won't read it every single time, but you make sure and you review it so you understand what happens with the bone marrow. They produce the immature cells, it develops into the leukemic white blood cells. Make sure you review that. But what are the risk factors? If there's previous cancer treatment we talked about, if they've been on chemo or radiation, they're going to have a higher risk. If they're exposed to radiation, they're going to have a higher risk. If there's a genetic disorder, we talked about Down syndrome. If they have a brother or a sister, which is genetics, a sibling, they are also at risk for ALL. So while these slides seem to be a lot of information, you'll notice as we're going through them, a lot of it is repetitive, right? So you'll see the same thing, and I won't read it every single time, but you'll see that they're a little bit repetitive. So the treatment for acute lymphocytic leukemia or ALL falls into 3 phases. We have the induction therapy. That's the first phase. The purpose of the first phase is to kill most of the leukemia cells in the blood and the bone marrow, just to restore a normal blood cell production. That's induction. The consolidation therapy called post-remission therapy. At that phase, they're aimed at destroying any remaining leukemia in the body, like the brain or the spinal cord. The maintenance therapy is the third phase. This is a treatment that's going to prevent the leukemia cells from regrowing. Okay, so this one is given at a much lower dose and over a longer period of time. So you're getting in there, you're taking care of the problem, and then you're maintaining it. So preventative treatment to the spinal cord here, during each phase of therapy, people with ALL are going to receive additional treatment to kill leukemia cells in the CNS. This type of treatment, chemo drugs, are often directly injected into the fluid that covers the spinal cord, okay, to help with controlling it. So AML, that's just like I say, very brief, basic information. You don't have to go into a lot of detail. If you plan to work in oncology, you'll have to specialize and get into more detail. But for the exam purposes and for NCLEX purposes, just know basic information about these different types of leukemias, the signs and symptoms, medication that you might use, and what the treatments would be. And they're pretty much the same, as you'll see. So for AML now, for AML, cancer again of the blood and the bone, which you guys know, the word acute Same thing I just said. It shows that there's a rapid progression, and it's called myelogenous leukemia because it affects a group of white blood cells called your myeloid cells or your myeloid cells, which we know develops into blood cells, mature red blood cells, white blood cells, and platelets. So AML, known as acute myeloid leukemia, acute myeloblastic leukemia. So there's different names for this. So just be aware of AML. If you see acute myeloid leukemia, what that is. So general signs and symptoms, you guys need to know some general signs and symptoms at the early stage may mimic those of the flu, which we just talked about. Think about what it's affecting. So it's based on the type of blood cell that's affected. We get the fever, the bone pain, they're tired and weak, fatigue, shortness of breath, pale skin, frequent infections, easy bruising, and also nosebleeds. So far it looks like the same thing we just talked about with ALL, right? So the risk factors now, so this AML is caused by damage to DNA, developing in the bone marrow. So these abnormal cells, they cannot function properly, they build up and they crowd out all the good healthy cells. So all the immature, abnormal cells are crowding out all the good ones. So let's think of the risk factors. Increasing age. So it says that acute myelogenous leukemia is most common in adults at 65 or older. So the older you get, you have more of a risk. Men are more likely, this is the first time now we're seeing gender, right? So men are more likely to develop AML than women. If they've had previous cancer treatments, that's pretty much for all of them. Exposure to radiation, we've seen pretty much for all the other cancers as well with leukemia. If they have exposure to dangerous chemicals, if they smoke, if they have a blood disorder. So we haven't really seen too much of that yet, but blood disorders. So if they have myelodysplasia, myelofibrosis, polycythemia vera, thrombocythemia, these are going to be greater risk. And we talked about some of these in previous weeks. So make sure you guys look at all the information. You understand that blood disorders is a risk factor. Also genetic disorders, which we looked at as well. So some tests that can be done, nothing unusual here. We can do a blood test. So you're trying to see now the presence of the blast cells, which are the immature cells. They're found in the bone marrow, but they're not circulating in the blood. That's an indicator of acute myelogenous leukemia. We do a bone marrow test, which we just talked about. We do a lumbar puncture. We haven't seen that one yet, but we could do a lumbar puncture or a spinal tap. So we take out some fluid around the spinal cord. We check it for leukemia cells. Genomic testing. So lab testing of leukemia cells identifies specific genes, chromosomal changes, anything that's unique to the leukemia, and find these genetic changes or mutations. So genomic testing is another way we can diagnose. So how do we treat it now? There's two phases. They have remission induction therapy. We have consolidation therapy. So for remission induction, this is where the first phase of treatment is to kill that leukemia cell in the blood, in the bone marrow. However, remission induction doesn't usually wipe out all the leukemia cells. So what do we have to do? Further treatment to prevent that disease from coming back. So consolidation now, called post-remission therapy or maintenance therapy or intensification. If you see any of those words, it's the same thing. In this phase, they're going to be aiming it at destroying the remaining leukemia cells. This is crucial to decreasing them relapsing. If you just do that remission induction, you think you got all of it, but you don't do the consolidation, now it comes back. So this is very crucial to maintaining it. It's similar to a patient that has very high blood pressure. Uncontrollable. You put them on the IV drips, you get the blood pressure down to where it needs to be. Now you're discharging them home. You're not going to keep them on a drip. You're going to put them on maintenance blood pressure meds to maintain that level so it's not going to keep spiking. So if you think of it like that, for those of you that are into, your cardiac, I did that for John. So if you think of it like that, that is similar to thinking of AML treatment. You are getting them on the medication, taking care of the problem, and then you're keeping them on something to destroy the remaining leukemia cells, but you're maintaining them on that so it doesn't come back. You don't want to relapse, okay? So some other therapies, like I said, you guys are going to see these often. We have chemotherapy, which is a major form of remission induction. It can also be used for consolidation. So people with AML will stay in the hospital during the chemo treatments because the drugs are going to destroy many normal blood cells as well, while it's trying to kill the leukemia cells. So in the first cycle of chemo doesn't cause remission, or if the first cycle doesn't cause remission, they can repeat it. Targeted therapy we talked about, they attack specific vulnerabilities in the cancer cells. Other drug therapy they have are anti-cancer drugs. They're used alone or in combination with chemo for remission induction. And then bone marrow transplant is where they actually call stem cell transplant, may be used for consolidation therapy as well. So these bone marrow transplants help to reestablish healthy stem cells by replacing the unhealthy bone marrow with leukemia-free stem cells. And what that does is it's going to regenerate healthy bone marrow. So that's very important. Okay, so now we have our CLL. So your CLL, let me go back to my slides. Chronic lymphocytic leukemia, it is same thing we just talked about. This is pretty much the same for all of them. It's a cancer of the blood and the bone marrow, spongy tissue inside the bones, where the blood cells are made. That's all the same. Chronic now refers to the fact that it progresses more slowly, and it most commonly affects older adults. So there are treatments. So people that have CLL, they have no early symptoms, and those who do, enlarged but painless lymph nodes, fatigue, fever. They got pain in the upper left portion of the abdomen, which can be by the spleen, night sweats, weight loss, and frequent infections. So you see some of these are overlapping. So the risk factors, so doctors, it says, they're not certain what starts the process of CLL. What is known is that something happens with the genetic mutation of the DNA. So what happens, we know, is it crowds out the healthy cells out of the bone marrow, interfering with the normal blood cell production. So what are the risk factors? Age, so now over 70, they're at risk. Race, so depending on your race, so Caucasian versus African American. So in this case, Caucasian are more likely to develop the CLL. Family history of blood and bone marrow cancer. Family history and hereditary and genes is always going to be a risk factor. It's a non-modifiable risk factor. Exposure to chemicals, depending on where the patient works, what have they ever been exposed to, is also a risk factor. Some complications that can happen. Frequent infections, so people that have CLL are going to experience frequent infections, because think about where it's affecting. So these infections are common in the upper and lower respiratory tract. A switch to more aggressive forms of cancer. So people who have had chronic lymphocytic leukemia or CLL may also develop an aggressive form of cancer called diffuse large B-cell lymphoma, or Richter syndrome. Increased risk of other cancers will also be a complication if they've had something else. And then immune system problems. So people that have CLL may develop immune system issues because the disease-fighting cells of the immune system may mistakenly attack the red blood cells or the platelets. So the test that would be done, they will do where they count the number of cells in a blood sample. Sounds like a game. So a complete blood cell count is used to count the number of lymphocytes. A high number of B cells or one type of lymphocyte indicates CLL. Determine the type of lymphocytes involved. They can do a flow cytometry, which determines if there's an increased number of lymphocytes. If chronic lymphocytic leukemia is present, the flow cytometry is going to help analyze the leukemia characteristics to show just how aggressive these cells are, because remember, it's chronic, it's taken a longer time. So we also can use FISH, which is fluorescence in situ hybridization. This is going to examine the chromosomes inside the abnormal lymphocytes. They're looking for abnormalities with that. So doctors will use this information now to determine what's the prognosis, what is the treatment. So here's a treatment now. Once we've diagnosed them and we've got a treatment, the doctor is going to look at the stage. So they're going to stage the CLL or the CML to assign a stage. So early, intermediate, or advanced indicates progression of the disease. People with early stage do not receive treatment. Studies have shown that early treatment does not extend the life for people that have CML, but doctors carefully will monitor the condition and reserve treatment for when leukemia progressive. They call this watchful waiting, not just for leukemia, but they do it for other illnesses as well. So it's called watchful waiting. And I noticed that on this slide, guys, and I actually made the corrections on here, they have CML at the very, very top. Right here, it says CML, chronic myelogenous leukemia. So this in my notes, let me find this part in my notes. I want to make sure that you guys have this correctly. I will have to make the changes on your slide so you understand CML, because here it says CLL. So we are on, let me find the correct slide. I want to make sure you guys have the information. CML, wanted diagnosis. Let me go back. We talked about that. So here we go. So this should be CM. Let me just do this. So this, instead of CLL, it's CML. I just want you guys to understand that that's what these slides are. It should be CML on here. Okay, so don't get yourselves confused. I will make the changes and send it to be revised, but this should really be your CML. So if chronic, here we go. If chronic CML is progressing or is in the intermediate or advanced stages, these are your treatment options. I didn't write them all out again because they're the same ones you've been talking about. So this is what I want to change. As new and more effective drug combinations have been developed, bone marrow transplant has become a less common in treating this should be ML, so CML, okay? That looks like an L and an L. It's CML, there we go, okay? So just so you guys are clear, don't be confused by the acronym, it's CML. So for sarcomas now, so sarcomas are a type of cancer that occur at various locations in the body. It is a general term for a broad group of cancers. It begins in the bones and in soft connective tissues called soft tissue sarcoma. So soft tissue sarcoma forms in the tissues that connect, support, and surround the body structures, which includes your muscles, your fats, your blood vessels, nerves, tendons, and linings of the joints. There are more than 70 types of sarcomas. Don't worry, I have to memorize all of them, but just be aware there's many of them. But the treatment is going to depend on the sarcoma type, where it's located, and any other factors that go along with it. Okay, so there's a lot of different types of sarcomas. We don't go into all of them. I'll just go into a couple. We have Ewing sarcoma. It is a rare type of cancer. It occurs in the bone or the soft tissue around the bone. It often begins in the long bones of the pelvis, the legs, or the arms, but really could occur in any bone. Less often, it may start in the soft tissue of the arms, legs, abdomen, but usually it's the long bones. So advancements in the treatment of Ewing sarcoma has significantly improved outcomes. After completion of the treatment, people live or need a lifelong monitoring for potential late effects of chemo and radiation. Ewing sarcoma is common in teenagers and young adults, but it really can happen at any age. The cause is unknown, but it arises from a specific type of cell, and it does not appear to be inherited. So that's the difference. We've been looking at leukemia versus sarcoma. This one is not really inherited. So some signs and symptoms could be, so please, like I said, review your signs and symptoms. So this is for sarcoma, Ewing sarcoma: pain, swelling, tenderness in the area, bone pain, which is worse at night or with physical activity, just tired, fever with no cause, weight loss, and broken bones with no cause. Imaging tests to evaluate the area. You guys know what these are already: CT, MRI, or a bone scan. This is how we are going to evaluate the area. Types of biopsy procedures that we use to diagnose Ewing sarcoma: they can do a needle biopsy, where they literally just put a needle in there through the skin. They go to the tumor, they remove a small piece of tumor to biopsy it. Surgical biopsy, where they go back into the skin, they remove the entire tumor, excisional biopsy, or a portion, incisional biopsy, and take it to the lab to see what's going on. So doctors perform the biopsy in a way that's not going to interfere with future surgery to get rid of the cancer. So after the diagnosis, the stage of the cancer is going to be determined. How far it's spread, has it gone to other areas, where is it localized, what's going on. So for localized Ewing sarcoma, it has not gone beyond its origin or the nearby tissues. For metastatic, it's spread to other areas of the body. That's going to depend on the type of treatment that we need. So we're looking at localized versus metastatic. Though rare, osteosarcoma is the most common type of bone cancer. It begins in the cells that form the bone. See, osteo, think of, remember back to ANP. So it's rare. It occurs inside maybe soft tissues or outside the bone, but it's most often found again in the long bones, arms and legs. Okay, it can start anywhere, but it's most often long bones. So it tends to occur in teenagers and young adults, could also be younger children or even older adults, but it involves chemotherapy and surgery. Radiation is not effective in treating it, but there are new improved radiation techniques like proton beam they're using that's being studied right now. But the treatment has improved over the years. So the prognosis and treatment decision is going to depend on where the osteosarcoma starts, the tumor size, the type and grade, whether the cancer has spread, is it metastasized, and then after completion of treatment, people once again need lifelong monitoring for potential late effects of this chemotherapy that they're going to be on. So some signs and symptoms of this osteosarcoma, among others: swelling near a bone or joint pain or bone injury, or even the bone breaking. And then factors that increase the risk are going to be, once again, previous treatment with radiation or inherited genetic conditions would also be increasing the risk of osteosarcoma. So the osteosarcoma can spread from where it has started to other areas, making that treatment and recovery more difficult. So surgery now that removes this tumor and spares the limb is often, most often the norm. But for some patients that require amputation, they now have to learn to use a prosthesis, okay? As with other types of this cancer, aggressive chemo can be a substantial side effect, both in long and short term. So you have to have a conversation with the patient, let them know that there's chemo, it's very aggressive. Sometimes patients will decline and then they go on to hospice. They might decline the chemo. They say, you know what? I want to just live my life. I'm not going to do the chemo. It's going to make me feel worse. The treatment is worse than the cure. So, they're not going to bother. It's up to the patient at that point. But there's imaging tests that are going to be used to find out if it's spread. And these are ones that we've just talked about: X-rays, CT, MRIs, PET scans, and even a bone scan. So the types of biopsy procedures to diagnose, we talked about needle, we talked about surgical. Excisional, which is the whole thing, incisional is just a part of. We do the biopsy. The extent for surgery is going to depend on the tumor size, the location, and the person's age. Can they have the surgery? Can they maintain having the surgery and be okay once it's done? Because a lot of times it's about the recovery. So they might do a limb sparing surgery where they're going to focus on removing the tumor and sparing the limb so function can be maintained. Whether this is feasible depends on the extent of the cancer and then also how much tissue and muscle need to be removed. For amputation, it's, with advancements in limb sparing, the need for amputation has decreased lately. But if it is necessary, it's because the cancer is spread too far, and now the patient has to get prosthetic joints just to try to live, live an improved life without the cancer. Then we have to think about doing patient teaching, have them look at the lost limb, the phantom pain, all the things that go along with that as well. As a nurse, that's what we have to do. We have rotation plasty. So in this surgery now, it's used for children who are still growing. Remember, their bones are still growing, right? They have the plate and they have their line, the epiphyseal line. So the surgeon removes the tumor in the surrounding area, including the knee joint. The foot and ankle are then rotated so the ankle functions as a knee. The prosthetics is used for this lower leg and foot, and results are going to typically enable the person to function very well. So chemo and radiation select cases as well. So rotationplasty, if you guys are able to Google it or read about it more, it's very interesting type of surgery. Okay, so chondrosarcoma, is that the last one we have? I want to get to the cancers before we take our break, and then when we come back, we'll do screening methods and also medication. So we have the chondrosarcoma. It's a rare type of cancer. It begins in the bone, but sometimes also the soft tissue near the bone. And the most common locations would be pelvis, hip, and shoulder. Okay, so the defining characteristics of this chondrosarcoma, its cells produce cartilage. So some types of these chondrosarcomas grow slowly, and provided they are removed completely, they have a very low risk of spreading to other organs and bones. Some grow very rapidly and they have a high risk of metastasis. So surgical removal of the tumor is the mainstay of chondrosarcoma treatment. Also chemo, also radiation can be helpful. The signs and symptoms are going to be increased pain. There's a palpable mass that feels swollen, fractures due to weakened bones, which makes sense because that's what it affects. So while chondrosarcoma can happen at any age, it really affects middle-aged to older adults. Ollier disease and Maffucci syndrome, these are conditions marked by increased number of benign cartilage lesions. They're sometimes transformed into chondrosarcoma. So because most of these chondrosarcoma tumors, they grow so slowly, once again, it takes years for them to be diagnosed. So in some cases, patients will go in for one thing and then they get an imaging testing done and then they're like, the doctor's like, oh, what is this? Then they diagnose and realize that they have chondrosarcoma. So a biopsy then is needed to confirm the diagnosis. So many times cancers are they're diagnosed or they're discovered when the patient goes in for something different. So they can do an x-ray, they can do an MRI and even a CT scan. They also can do a biopsy. They remove a piece of it, you know, to see what's going on. The biopsy is done in a way, like I said, so it doesn't affect removing the cancer during a later operation. Surgery is the primary treatment for chondrosarcoma. The goal is to remove all the cancer and a margin of healthy tissue around it. But the type of surgery is going to depend on the location of the chondrosarcoma. So it just depends on where it's located. Most of these chondrosarcomas are suitable for limb salvage surgery, where the cancer is removed and the affected bone is either replaced or reconstructed. A small percentage will be amputation. They're trying to not to have to amputate, but if they need to, the option is chosen when a tumor involves major nerves, blood vessels, or it is so large that it destroys the function of the limb anyway. So they have to remove it and they get a prosthesis instead. So for sarcoma lymphoma now, lymphoma is a cancer of the lymphatic system, which is, we know, what we use to fight germs. That's our body's germ fighting network. The lymphatic system has your lymph glands, your spleen, your thymus, your bone marrow, and the lymphoma affects all those areas and even others as well. There is many types of lymphoma. The main subtypes that you guys will see would be Hodgkin's, formerly called Hodgkin's disease. You may see it as Hodgkin's lymphoma now, non-Hodgkin's lymphoma. And what lymphoma treatment is best is going to depend on the lymphoma type and its severity. So lymphoma treatment may involve chemo, immunotherapy medications, radiation therapy, bone marrow transplant, or even a combination of all of that. So here are the types, and like I said, I don't think I went into details on every single one. I just want you to be aware of the different types of, so just review the types, okay? These are all the different types. We talk about some of them, but the signs and symptoms are gonna be painless swelling of the lymph nodes. Makes sense, that's what it's affecting. Persistent fatigue, fever, night sweats, shortness of breath, and unexplained weight loss. All of those we've been seeing throughout lecture today. So here, look at the factors now that increase the risk. Age, so people over 55 now. Male again, remember we talked about gender, male versus female. Having impaired immune system makes sense because lymphoma is more common in people that have immune disease or they're taking drugs that suppress their immune system, developing infections. So some infections associated with an increased risk of lymphoma, Epstein-Barr, Helicobacter pylori infection. Those are the ones that we have to worry about. Those are the ones that have a higher risk. This is why we do a good H&P. We find out about all this about the patient. That way we can put it together when we're taking care of them and let the doctor know, listen, this person has a history of, and then we wonder why they have this lymphoma. So some tests and procedures that we do, always a physical exam, checking for swollen lymph nodes, neck, underarm, and groin, swollen spleen or liver. They may remove a lymph node for testing. So they'll do a biopsy in the lab just to see what's going on, what types of cells are involved, you know, what's present, what's happening. Blood tests, so we're going to count the number of cells to let us know what the diagnosis is. They may remove a sample of bone marrow for testing again, so bone marrow aspiration and a biopsy, and also imaging tests. They do imaging tests for everything, right? CT, MRI, and PET scan to look for signs of lymphoma in other areas as well. So lymphoma treatment is going to include active surveillance. So we talked about watchful waiting. Watchful waiting, is that what I said right? I don't know. When you take a look and you keep an eye on the patient, I can't remember if that's exactly the way they word it, but now we have active surveillance. So doctors may decide to wait to treat lymphoma when it causes signs and symptoms that interfere with daily activities. Until then, they may undergo periodic testing just to monitor to see how it's growing. So they will active surveillance, so keep an eye on it. Chemotherapy, again, pills or IV medications are administered. Other drug therapies, so we're going to focus on the specific abnormalities in the cancer cell, specific areas. Radiation therapy, we're using high-powered beams of energy to kill those cells, and even a bone marrow transplant where we're trying to infuse into the blood healthy stem cells to rebuild that bone marrow. Hodgkin's lymphoma. So Hodgkin's lymphoma, like I said, formerly known as Hodgkin's disease, cancer of the lymphatic system, which we know is your immune system. It affects people between the ages of 20 and 40 and those over 55. So for Hodgkin's, the cells in the lymphatic system, they're abnormal and they spread beyond. So Hodgkin's lymphoma is one of two types of cancers of the lymphatic system. We have non-Hodgkin's as well, which is far more common. So advances in diagnosis and treatment of Hodgkin's has helped people with this disease have full recovery, but the prognosis continues to improve for people that have Hodgkin's lymphoma. So signs and symptoms of Hodgkin's is going to be, once again, painless swelling of the lymph nodes, persistent fatigue, fever, night sweats, weight loss, itching. We haven't seen itching so much yet. Increased sensitivity to the effects of alcohol or pain in the nodes after drinking alcohol. We haven't seen that yet. So doctors are not really sure what causes Hodgkin's lymphoma. They're not sure, but it begins when the infection-fighting cells called your lymphocytes develops a genetic mutation. They're rapidly multiplying, but they're not doing much to help us. So we have a large number of oversized abnormal lymphocytes. They accumulate, they crowd out the healthy cells, causing symptoms of Hodgkin's lymphoma. So classical Hodgkin's lymphoma is the more common type of the disease. People diagnosed with it have large abnormal cells called Reed-Sternberg cells in their lymph nodes. Nodular lymphocytic or lymphocyte predominant Hodgkin's lymphoma is a rarer type of Hodgkin's involving large abnormal cells, sometimes called popcorn cells because of how they look. Treatment may be different from the classical type. People with this type of Hodgkin's lymphoma may have a better chance of a cure when we diagnose at an earlier stage. So factors that will increase the risk will be age, so between 15 and 30 and over 55, family history, being male, and then a past Epstein-Barr infection. So people who've had illnesses caused by Epstein-Barr viruses, such as mononucleosis, are more likely to develop Hodgkin's lymphoma than people who have not had Epstein-Barr. So what do? We do a physical exam, always a physical exam, blood testing, imagings again, and we're going to remove the lymph node for testing. So we're going to biopsy, see what's going on, and then removing a sample for bone marrow of testing. So we're looking at the sample for Hodgkin's lymphoma cells. Here are your stages. So think about stage 1. The cancer is limited to one lymph node region or a single organ. That's stage 1. In stage 2, the cancer is in 2 lymph node regions, and the cancer has invaded one organ and the nearby lymph node. But it's still limited to that section of the body, either above or below the diaphragm. In stage 3 now, the cancer has moved to the lymph nodes both above and below the diaphragm. This is stage 3. Cancer may also be in a part of the organ or tissue near the lymph node group or even in the spleen. At stage 4, it's the most advanced stage. Cancer is now in several parts or more than one organ or tissue. It not only affects the lymph nodes, but now other parts of the body. So the liver, lungs, or the bone, it's metastasized. We also have letters A and B to indicate whether the patient is experiencing symptoms of Hodgkin's lymphoma. So if it's A, it means the patient has not had any significant symptoms as a result. And if it's B, it shows that the patient has had significant signs and symptoms, persistent fever, for example, weight loss, or night sweats. So A and B. So they stage it and then they put letters to it. So Hodgkin's lymphoma treatment, it depends again on the type and stage of the disease, overall health and preferences. And the goal of treatment, as with any cancer, is to destroy as many cancer cells as possible and get that disease into remission. So we do chemo with radiation with people that have early stage classical Hodgkin's lymphoma. Radiation is typically done after chemo, and in advanced Hodgkin's, chemo may be used alone or in combination with the radiation. So radiation therapy, high beams, they kill the cancer cells. For classic Hodgkin's lymphoma, radiation again therapy is used after chemo. Bone marrow transplant, also known as stem cell, we're going to try to get healthy bone marrow in there to grow. Despite a bone marrow transplant may be an option for Hodgkin's lymphoma if it returns despite being treated for it. So for adult non-Hodgkin's now, for non-Hodgkin's lymphoma, NHL they call that, it's a malignant cancer. It begins again the lymph nodes or the lymphatic system. This is the area that we used to fight. It means that the disease has spread from where it started and now it invades other body areas. Excuse me. So adult non-Hodgkin's differs from lymphoma in children. It has a different course of treatment. Non-Hodgkin's means the absence of these cells called the Reed-Steinberg. So these don't have that. It is the cancerous tissue or in the cancerous tissue. Symptoms will be painless swelling, again, the lymph nodes, unexplained fever, heavy night sweats. You're feeling more tired, unexplained weight loss, itching or rash, and pain in the chest, abdomen, or bones. So we haven't seen that yet. So now we're getting pain in the chest, the abdomen, or the bones. So the non-Hodgkin's lymphoma risk factors, again, older white male having the following conditions: inherited, autoimmune disorders, HIV/AIDS, we got human T lymphotropic virus type 1 or Epstein-Barr. We got bouts of Helicobacter pylori, immunosuppressant drugs, pesticides exposure, radiation exposure, diet with a lot of high meat and fat content, and previous treatment for Hodgkin's lymphoma. These are all risk factors for non-Hodgkin's lymphoma. So the diagnosis, we want to do a physical exam. We want to know about a medical history, any lumps that are not normal, blood tests to measure levels of all the blood cells, red, white, and platelets. We want to do blood and urine tests to look at the amount of immunoglobulins in the system, bone marrow aspiration or biopsy to look for any signs of cancer, even a lymph node biopsy. So we're removing part of the lymph node now to examine it for signs of cancer. So the diagnosis, it's a very treatable disease. Before treatment begins, we need to know how far the cancer has gone. So this is called stage of the disease. It begins with least severe, 1 to 4, through most severe, Roman numerals. So stages of adult non-Hodgkin's lymphoma may include E, extranodal, which means the cancer has spread beyond the lymph nodes, and S, meaning that the cancer has been found in the spleen. So because it's a blood and lymphatic system disease, most patients are already at an advanced stage of diagnosis. It comes in many types. It's divided into indolent, which is slow moving with a few symptoms, or aggressive, growing quickly and lots of symptoms, causing lots of symptoms. So these behave differently. They're treated differently, okay, depending on how we're treating them. So there are several types of treatment to kill the cancer cells, to keep them from dividing. We do radiation, okay? We do chemo. We do targeted, which we talked about. Biologic therapy, where we use substances or cells made by the patient's own immune system or in a lab to help boost the body's natural defenses. Some patients with indolent lymphoma that's not causing problems, they do not need treatment. It's called, that's the word I was thinking of, watchful waiting. I don't know if I said something else before. Watchful waiting. It is the close monitoring of the patient without giving any treatment until they start to show signs or symptoms, okay? So watchful waiting. I won't forget that now. For multiple myeloma, we could probably get through multiple myeloma and then we'll take a break. So for multiple myeloma, it's a cancer that forms in a type of white blood cell called a plasma cell. Plasma cells, as you guys know, fights infection by making antibodies that recognize and attack. So multiple myeloma causes cancer cells to once again accumulate in the bone marrow. They crowd out the healthy blood cells, and rather than producing helpful antibodies, these cancer cells produce abnormal proteins, which causes complications or problems. So treatment is not always necessary for people who are not experiencing signs or symptoms, but for people with multiple myeloma who require treatment, we have different things that they can do to control that disease. So signs and symptoms of multiple myeloma can vary, and early in the disease, there is no signs and symptoms. When they do occur, the bone pain, spine or chest, nausea, constipation, loss of appetite, mental fogginess or confusion, fatigue, infections, weight loss, numbness in the legs, weakness in the legs, and excessive thirst. So notice now we have a bunch of different symptoms we haven't seen before. Right now we have constipation, we have excessive thirst, we're looking at pain in the spine or chest, mental fogginess. So these are some things we haven't been seeing yet. Myeloma begins with one abnormal plasma cell in the bone marrow, and these abnormal cells multiply rapidly. So because these, like I said, cancer cells do not mature and then they don't die as they're supposed to die normally, they accumulate, they overwhelm the production, and now you have a bunch of cells that can't help you, crowding out the cells that can. So myeloma cells continue trying to produce antibodies as healthy plasma cells do, but the myeloma cells produce abnormal antibodies that our bodies cannot use. So instead now, the abnormal antibodies are going to build up and cause problems such as damage to the kidneys in your body. So cancer cells can also cause damage to bones, increasing the risk of broken bones. This is your multiple myeloma. So it almost always starts out as relatively benign, called monoclonal gammopathy or undetermined significance, MGUS. So like multiple myeloma, it's marked by the presence of M proteins produced by your abnormal plasma cells in the blood. But these levels in MUGS, MGUS, the levels of M proteins are lower and no damage to the body occurs. Complications, however, for multiple myeloma would be frequent infections because you're not able to fight the infections off, bone problems because it's affecting the bones, leading to bone pain, thinning bones, broken bones, reduced kidney function. So now we're looking at kidney failure. There's higher levels of calcium buildup, eroding the bones, interfering with the kidney's ability to filter the waste, and the proteins now produced by the myeloma cells are going to cause similar problems. We also have anemia, so they're crowding out the normal blood cells, and it's causing other blood problems. We can do blood tests, so they can do labs, blood tests to reveal M proteins produced by the myeloma cells. We can do urine tests to show the M proteins, referred as Bence-Jones proteins when they are found in urine. We examine the bone marrow. So this is a fish, again, we just talked about, which we can analyze the myeloma cells to understand the abnormalities in their genetics, and also to understand and measure the rate at which they're dividing. And then, of course, your imaging tests, CT, MRI, PET scan, X-rays. So if the test indicates that we have multiple myeloma for a patient, they're going to classify stage 1 or 2, stage 3, indicating stage 1 indicating a less aggressive disease, and stage 3 meaning aggressive disease. It affects the bones, the kidneys, and the other organs. We can do targeted treatment, biologic therapies. So for targeted treatment, we're going to focus on specific abnormalities within the cancer cell, and they're going to block the action of that substance in the myeloma cells that breaks down the protein, causing the myeloma cells to die. They can give this therapy either pill or IV. Biologic is when we use our body's immune system to fight these myeloma cells. We can enhance our immune system, attack and fight these cells, and this is taken in pill form, the biologic therapy. We can do chemotherapy, where this chemo is going to kill these fast-growing cells, including the myeloma cells. Corticosteroids, which are going to regulate the immune system, control the inflammation. They also are active against myeloma cells. We can do a bone marrow transplant to replace the diseased bone marrow with healthy bone marrow, and even radiation, where we use the beams of energy to damage these cells and stop them from growing. So because these multiple myelomas can cause a number of complications, patients also need to be treated for those specific conditions that are a complication. So for bone pain, medication, radiation therapy to control it, kidney complications, they might need dialysis, infections, we can give vaccinations, bone loss, they use biophosphonates, which, to prevent the bone loss, and then anemia. We're going to give medications to now increase the red blood cell count, okay? So that is, it's 6:04, 6:05. That is the end of the lecture part for the types of leukemia. What I want to do next when we get back from break, since it's just me and John, what I want to do when we get back from break, I'm going to go over the screening methods and diagnostic tools, and then also we're going to talk about the medications, many of which I probably cannot pronounce, but that's okay. As long as you can identify them, that's all I want. So I'll take about 10, 12 minutes or so, and then when I get back, we'll continue with the remaining PowerPoints for lecture. Okay, I'll see you in a little bit. Okay, I'm back. Let me just shrink myself and move over in the corner. Okay, so here we go. We are on screening methods and diagnostic tools. So some of these you probably may have seen before, me either in practice or just knowing about it from before, but we're going to go over these different screening tools or diagnostic tools that are going to show us or influence the patient's response to the prognosis for these abnormal cellular growths we've been talking about. So these are the screening tools we're going to talk about in lecture. You can always look up if you want more information. I just want to give you guys a brief, just general, to the point, couple slides on each of them. I don't think I went into too much detail, just to highlight a few things that you may want to know about, like, for example, a mammogram. So it's an X-ray picture of the breast. They are used to check for breast cancer in women who have no signs or symptoms of the disease. This type of mammogram can be called a screening mammogram. Screenings will involve 2 or more X-ray pictures or images of the breast. So X-ray images are going to make it possible to show tumors that cannot be felt. Screening mammograms can also show us deposits of calcium that may indicate the presence of breast cancer. So they're also used to check for breast cancer after a lump or signs or symptoms of the disease has been found. So this is called diagnostic. So there's different ways we can use a mammogram. Besides a lump, or signs of breast cancer can include breast pain, thickening, the skin of the breast, nipple discharge, change in breast size or shape. This is why we teach our patients about self-breast examinations and why they should be getting checked. Diagnostic mammograms are also used to evaluate changes during a screening mammogram or to view this breast tissue when it's hard to obtain a screening mammogram because of special circumstances, especially nowadays, a lot of breast augmentation that happens. So there's different ways to check so that we're aware what's going on in there. So these are how we check the results. We can have a false positive. With a false positive, this is when the radiologist may see an abnormality, but on the mammogram, but no cancer is actually present. That's a false positive. False positive results are more commonly for younger women, women with dense breast tissue, women who've had previous breast biopsies or with a history of breast cancer or even taken estrogen. There's also a false negative result. This is going to be a negative result means no abnormalities present, but a false negative is when the mammogram appears normal, but there is breast cancer present. One cause of this could be high breast density. So breasts contain dense tissue, they contain fatty tissue. Fatty tissues appear dark, whereas fibroglandular tissue appears as white. Because these fibroglandular tissues and tumors have similar density, these tumors are going to be harder to detect in women that have denser breasts. So false negatives are going to occur among young women more than older women, because younger women have more dense breasts. So as a woman ages, her breasts become more fatty, and a false negative may be more likely. So understand the difference between false positive, false negative. I put examples on there for you guys so you can read and understand what they mean. A colonoscopy now is an outpatient procedure. It's not pleasant for people, where they go in. The inside of the large intestine and colon and rectum are going to be examined. So it's used to evaluate GI symptoms, rectal intestinal bleeding, or even changes in bowel habits. Colonoscopies are performed for colorectal cancer screenings in individuals without symptoms to check for colorectal polyps or cancer. The screening is usually recommended for anyone over 50 years or 50 years and over. So colonoscopy or colonoscope is a flexible instrument that's used to view the lining of the colon. They insert it into the rectum, they advance it to the large intestine, and if it's necessary, they will sometimes remove tissue like a biopsy. The polyps are then identified and entirely it's removed. So in many cases, colonoscopy allows a very accurate diagnosis and allows us to know what type of treatment for this colorectal problem that we may need, depending on what type of operation we might need. So during the colonoscopy, and this is just a review for you guys, they put an IV in, the patient's given a pain reliever or a sedative, they feel a little bit drowsy. They're going to lie on the left side, the knee's going to be drawn up to the chest. They put a small amount of air to expand the colon so that the physician can see the colon. The patient is going to feel some cramping, and cramping is reduced by taking slow, deep breaths. They put in the scope, it's withdrawn, slowly withdrawn, while the lining of the bowel is carefully examined. It's about 30 minutes to an hour. So as a nurse, we're going to prep the patient, explain to them what they're going to feel, what they should do, things like that. So we're doing the patient teaching before. And we're also going to tell them what they're going to be needing to do afterwards, even before they've even had the procedure done. You just remind them again once it's over. So after the colonoscopy, they're going to be in recovery until we discharge them. They might have some cramping or even having gas, but that's normal and it will pass. If a sedation is given, they have to have someone drive them. They can't drive. No alcohol or driving or operating any machinery for 24 hours. Unless the doctor says differently, they can get back on their regular normal diet, but wait about a day or so after to resume normal activities. If they've taken polyps or biopsy, the doctor is gonna let them know when they should return on their blood thinners if they were on blood thinners. And if a biopsy was taken or a polyp was removed, let them know they're gonna have some light rectal bleeding for about a couple days after the procedure. If there's a high amount of rectal bleeding or persistent fevers or abdominal pain within the next couple weeks, they have to go to the emergency room. So we're doing all this patient teaching, like I said, before the procedure, after the procedure, you're reminding them so that they know what to look for, what's normal or abnormal following the procedure. Sigmoidoscopy. So this flexible sigmoidoscopy is an exam used to evaluate the lower part of the large intestine, the colon. And they put, during a flexible sigmoidoscopy exam, they put the tube into the rectum, they put a tiny video camera at the tip to allow the doctor to see what's going on in the rectum and most of the sigmoid colon. If they need to, they'll biopsy as well. They'll through the scope during this exam. So this flexible sigmoidoscopy doesn't allow the doctor to see the entire colon. So what happens is the cancer and polyps that are further into the colon may not be detected because they can only go so far. So after the exam, mild discomfort again, the patient might feel bloated or maybe have gas for a few hours as they clear the air out of the colon. Walking around is going to relieve some discomfort. They can get back on their normal diet right away. Small amount of blood with the first bowel movement, let the patient know that it's normal. It's not a cause for alarm, but if they continue to pass blood or blood clots or have persistent abdominal pain or a high fever, they need to go to the ER or let the doctor know. Negative results, if this is a result of a flexible sigmoidoscopy exam, are considered negative if the doctor does not find any abnormalities in the colon. If it's positive, this means that the exams are positive, the doctor has found polyps or abnormal tissue. Depending on these findings, we now have to do further testing. So any abnormalities that can be examined through, thoroughly biopsied or removed, we have to go further to find out what's going on. For your PSA, prostate-specific antigen, this is a protein that's produced by normal and also malignant cells of the prostate gland. This PSA test is going to measure the levels of PSA in the male patient's blood. For example, this test or blood sample is sent to a laboratory for analysis, and they use nanograms to see what the levels are. So the blood level of a PSA is often elevated if the man has prostate cancer. In addition to prostate cancer, benign, not cancerous conditions may also cause the PSA levels to rise. So the most frequent benign prostate condition that causes an elevation would be prostatitis, so this inflammation of the prostate. If they have BPH, benign prostate hyperplasia, which is enlargement of the prostate, will also cause this antigen to rise. We have a false positive result that occurs when the PSA is elevated but there's no cancer. A false negative is going to be when the PSA is low but the patient has prostate cancer, so it's the opposite. We have the CEA, which is your carcinoembryonic antigen. This is a tumor marker in the blood or body fluid that's used to monitor certain cancers like colorectal. When the levels are decreasing, it's showing that the cancer is responding to treatment. When it's increasing, we might have a recurrence, progression, or a spread, metastasis. So CEA is a protein that's made by the normal cells by the fetus during pregnancy, but it's often produced in a large amount by cancerous tumors. They're found in the blood, the urine, the stool, and body fluids, and also the cancerous tumor. It's more likely to be produced by well-differentiated tumors that are made up of cancer cells that appear very similar to normal cells than with a poorly differentiated tumor. So these CEA levels are not used alone. They're not used alone to monitor the cancer, but they're used along with other symptoms, other findings, tumor markers or biomarkers or imaging. So it's not just one thing that we use. We have to evaluate, we have to plan, but we have to figure out exactly what's going on. So we're monitoring based on H&P, tumor markers, imaging testing, what else, blood tests, whatever we need to do to figure out now how do we plan the treatment. So there's levels of CEA that are considered normal, and they may vary in labs within a couple numbers, but less than or equal to 2.5 in non-smokers, less than or equal to 5.0 in people who smoke. Cause of a high CEA level can mean either cancer or benign inflammatory conditions. Levels of 10.0 often means cancer. Levels of 20.0 means cancer has metastasized, and a very high level frequently seen with metastasis to the pleural cavity, peritoneal, and central nervous system. So I don't believe you have to memorize numbers for this. I just want you to know what this antigen is, what it does, and maybe what it means. I mean, the numbers aren't hard to memorize, but I want you to understand if you see a number that's over 20, that means it's very high. Less than or equal to 2.5. So just have a general idea of what the numbers are. So just in case, I don't know if you're going to get this on an exam, but in case you do, you're aware of if they say 5 or -2, I don't think they're going to say -2, but if they say something like that, you're aware of what the numbers should be, the range. Okay, so Pap smear is used to screen for cervical cancer. It's done when they do a pelvic exam for women that are older than age 30. Pap smears are combined with a test for HPV, which is a sexually transmitted infection that causes cervical cancer. Doctors recommend Pap testing every 3 years for women that are age 21 to 65. Women that are 30 and older can do a Pap testing every 5 years. With risk factors, the more frequent Pap smears, regardless of age, is recommended. These would be diagnosis of cervical cancer, exposure to DES, dialstilbestrose before birth, HIV infection, weakened immune system, a history of smoking. Okay, think of the risk factors. So normal results. So if only normal cervical cells were discovered, normal cervical cells, this is considered a negative result. Then you don't have to do anything else until you get the next Pap smear or pelvic exam. If it's abnormal, this is when we discover abnormal or unusual cells in the Pap smear. It's positive. So a positive result doesn't mean there's cervical cancer. It just depends on the cells that are found. If the Pap smear is abnormal, they do a colposcopy, where they examine the tissues in the cervix, the vagina, vulva. They perform that. Tissue biopsy is taken in any areas that look abnormal for a definitive diagnosis. Complementary therapies. So this is just for your information, just for your info. I don't think you're going to have this on an exam, but hypnosis to combat depression, anxiety, nausea, pain, and cancer treatment or cancer patients. Acupressure, compression of blood vessels. Acupuncture, where they put the needles through the skin at specific points. Reiki, where they use manual healing. Variety of touch and manipulation like massage, and then guided imagery to induce relaxation. These are just complementary therapies. I had to stick that in there because not all your patients that you're going to have are going to want all these things done to them. They might just want something, complementary, which would be something like this. So just so you guys are aware, okay? So therapeutic touch is used for pain or utilized for pain or to induce relaxation. Homeopathic, it's to cure, attempts to cure utilizing small doses of drugs that produce symptoms of diseases. In healthy people, when administered in large doses, deficiency in vitamin A cause a reduced resistance to infection. Vitamin E, although they don't really know the exact mechanism, it's a required nutrient in humans. And deficiency in B vitamin is going to affect everybody's system, GI, endocrine, nervous, renal, and cardiac. So I want you guys just to see a little bit of what the complementary therapies are, just so that you're aware of it, okay? So let's move on into the treatment modalities now, surgical and non-surgical. So we have treatment for, other than medication that's used for abnormal cell growth, internal and external radiation, surgical, blood transfusions, and bone marrow transplant. So treatment for transurethral needle ablation of the prostate uses low frequency radio frequencies to produce localized heat to destroy the prostate tissue. These frequencies, they put thin needles in there to the prostate gland from a catheter, and the body reabsorbs the dead tissue. Very convenient. Microwave thermotherapy, this is where they use heat to the hypertrophied prostatic tissue in BPH. They put a probe in through the urethra, and the microbes are carefully directed to the prostate tissue. The affected tissue becomes necrotic and it sloughs off. Mohs myographic surgery for cancer removal is the most accurate and best conserves normal tissue because they remove it layer by layer. Each layer is excised, it's frozen. They analyze to determine if the entire tumor has been removed. That's Mohs. Electrosurgery is used to remove cancerous skin tissue by electrical energy. The tumor is removed and the base is cauterized. Cryosurgery destroys skin tumor by deep freezing. So just so that you're aware, there's different treatment modalities. Radiation is frequently performed for cancer of the eyelid, tip of the nose, areas in or near vital structures like the facial nerve. The skin becomes red and blistered after radiation, and they put ointment on there for discomfort. So palliative radiation is used to relieve symptoms of metastatic diseases when cancer has spread to the brain, the bone, or the soft tissues, or for oncologic emergencies. Radiation is administered externally or internally. External may involve X-rays, gamma rays, particle beams, depending on how deep that tumor is. Internal is where they put in, it could be beads, it could be little seeds, they call them, it could be wires. So internal radiation, where intraoperative radiation allows radiation to be applied directly to the affected area during surgery. So radiation dosage is dependent on the sensitivity of the tissue that you're targeting and the tumor site. So toxicity of radiation is localized to the region being eradicated. Body tissues that are affected are those that normally proliferate rapidly: the skin, the epithelial lining of the GI tract. Temporary altered skin integrity is common and includes alopecia, erythema, and also shedding, desquamatation of the skin. So alterations in oral mucosa second to radiation therapy would be stomatitis, xerotomia, change in loss of taste, decreased salivation. Esophageal irritation with the chest pain and dysphagia may also result. If the stomach or colon is in the irradiated field, anorexia, nausea, vomiting, anything that's going to happen or affect the stomach is going to cause issues of upset stomach, nausea, vomiting, diarrhea, until the epithelialization occurs and then the treatment is completed. If bone marrow producing sites are included, now we have anemia, leukopenia, thrombocytopenia. Think about the area that's being affected and what would make sense for complications in that area. Chronic anemia may happen. Systemic side effects that are common with radiation: fatigue, malaise, headache, nausea, and vomiting. So the patient that's undergoing internal radiation, they're going to be carefully observed. However, the nurse has to minimize their exposure to the radiation themselves as much as possible by applying principles of time, distance, and shielding. Okay, and I remember that being a question on an exam where they ask about which indicates proper teaching, that you need to have the patient do as much for themselves as possible. That way you're not in the room as long, because you're only allowed a specific amount of time to be in there. They don't ask about how long. They just want you to know as a registered nurse that you're not supposed to be in there for a long period of time. So nurses that are pregnant should not be involved in immediate care of that patient. Radiation implants should not cause severe pain. Mild opioids, muscle relaxants, or sedatives are helpful. Personnel that's coming in have to wear a film badge or a pocket ion chamber to monitor the radiation exposure. Rubber gloves are needed to dispose of any soil matter that may be contaminated, but these gloves do not provide protection from sealed radiation sources. So just important things to know. Nursing interventions related to the patient that's receiving radiation therapy, we have to always educate the patient and the family about the procedure, protect the skin, the mucosa, oral mucosa, protect the caregiver. We're always assessing skin, we're always assessing oral for changes, avoiding, and the skin, this should be protected from irritation, avoiding use of ointments, lotions, or powders in that area. Gentle oral hygiene is important. When the patient has a radioactive implant in place, the nurse needs to know about it, and they need to make sure that they protect themselves and other healthcare providers that are going into the room, like a nursing assistant, for example, that may not know. So nurses should explain the rationale for precautions to keep that patient from feeling that they are isolated. They are, but you don't want them to feel as though they're isolated, right? So we have to make sure they understand why their loved one has to be dressed that way, or why they can't be in the room for a long period of time. For blood transfusions, so administration of blood and blood products requires knowledge of correct administration techniques and possible complications. Patients are always typed and crossed before you give them the blood. The nurse should confirm the order for transfusion. Verify consent has been signed. You always verify with the second nurse about the order and the blood product for accuracy. Even if you've checked it, you still do a check with another RN. Patients' vital signs are obtained before you start the transfusion. If they don't have an IV access, they use a large gauge, a 20 gauge or larger, to get the blood in there. Patients are monitored and assessed every 15 to 30 minutes. You always stay with the patient. Do not leave them, at least for the first 15 to 30 minutes when you're doing this transfusion. If they have a reaction, you need to be there. The administration time should not take longer than 4 hours. The nurse has to be on alert for signs of adverse reaction, circulatory overload, sepsis, febrile reaction, allergic reaction, acute hemolytic reaction. Anything can happen, even if they've had blood before. If more than one unit of blood is to be transfused, the tubing should be changed after every 2 units to decrease the chance of bacterial contamination. If they are receiving platelets, a platelet count is ordered about 1 hour after infusion to make sure it's effective. Bone marrow transplant involves removing bone marrow from the patient or a donor and administering high doses of chemo. BMT is the treatment choice for patients with severe aplastic anemia younger than 50 and have a compatible donor. The patient's bone marrow spared from the effects of chemo is then reinfused with the IV or intravenously. The types of BMT is based on the source of the donor tissue, allogenic, autologous, or synergetic, depending on if it's from an unrelated donor, from the self, or from an identical twin. And then they explain that here. I'm not going to read all of this for you. Just be aware, or just review it, understanding that for allogenic, I always say I'm not going to end up reading it. Allogenic BMT is used primarily for disease of the bone marrow, depending on the availability of human leukocyte antigen match donor. I don't believe it's on your exam. I put it there for more information in case you are interested. So please review this. Okay, so nurse management or nursing management during the bone marrow or stem cell infusion consists of you're monitoring vital signs, you're monitoring the O2 sat, you're looking for adverse effects, and here's a whole list of them. You're always providing ongoing support and patient teaching. through the period of bone marrow aplasia until the engraftment, patients are at high risk for dying from sepsis and bleeding. So you are constantly monitoring your patient. They require support with blood products, hemopoietic growth factors. Late complications might occur 100 days later or afterwards. Infections, pulmonary abnormalities, recurrent pneumonias. We always educate our patients about what could happen, what to look for, when should you come back for follow-up. So for surgical intervention with the colon, so removing the cancer in operation is the most common treatment for all stages of colon cancer. They may do different types of surgeries: local excision and resection of the colon with anemostases or anostomies. I'm saying that so wrong. Local excision. If the cancer is found at an early stage, the doctor is going to remove it without cutting through the abdominal wall. They put a tube in there, they cut it out. It's called local excision. If the cancer is found in a polyp, they do a polypectomy. Okay, I'm saying that okay. Anastomoses. I knew the word. I just couldn't talk right now. Anastomoses. If the cancer is larger, the doctor is going to perform a partial colectomy where they remove the cancer in a small area of healthy tissue that's around it. So the doctor's then going to sew the healthy parts together. That's the word I couldn't say, anemostases. And the doctor is going to remove the lymph nodes near the colon, examine them under the microscope to see if they have any cancer in them. Here's a really good picture: resection of the colon with a colostomy. So the doctor's not able to sew the two ends back together. Now we now have a stoma. An opening is made on the outside of the body because the waste has got to get out. So the procedure is called a colostomy. Why can't I talk? A colostomy. And I take care of so many patients that have these. A bag is placed around the stoma to collect the waste. Sometimes the colostomy is needed until the lower section of the colon has healed, and then it can be reversed. So if the doctor has to remove the entire lower section of that colon, the colostomy now cannot be reversed. It's now permanent. So here's a picture of what it is, and here's the bag. Know those bags very well. So resection of the colon with anastomoses, excuse me. Part of the colon containing the cancer and nearby healthy tissue is removed, and then they have the join areas that they join them together. So surgery for rectal, intervention for rectal. So surgery is the most common treatment for stages of rectal cancer. Cancer is removed using one of the following: polypectomy, local excision, resection, radiofrequency ablation. Okay, so if the cancer is found in a polyp, they remove it with a coloscopy. So local excision, the cancer is found inside the surface of the rectum and is not spread into the wall of the rectum. They remove the cancer and a little bit of healthy tissue around it. Resection is going to be if the cancer is spread into the wall of the rectum. The section of that rectum with cancer and the nearby healthy tissue is then removed. Sometimes the tissue between the rectum and the abdominal wall is also removed. They check the lymph nodes near the rectum for signs of cancer. And then radiofrequency ablation, the use of a special probe with tiny electrodes that kill the cancer cells. So sometimes the probe is inserted directly into the skin through local anesthesia. In other cases, they put it through the abdomen, but it's done at that point in the hospital with general anesthesia. Here's a picture of this. We have cryosurgery, which uses an instrument to freeze and destroy the abnormal cells, tissues. Pelvic extenduration, this is where the cancer is spread to other organs near the rectum. Lower colon, rectum, bladder are removed. So in women, the cervix, vagina, ovaries, and the lymph nodes areas may be removed. In men, the prostate is removed. So then we have now an opening, stoma, for urine and stool to come out of the body into a bag. Okay, and then they show you a picture of that. So after the cancer is removed, the surgeon is going to do an anemostasis. Oh my gosh, today, just forgive me, guys. It's been a long day. as stomaces. Okay, they sew the healthy parts of the rectum together. I did say it right one time, okay? So don't laugh at me. They sew the remaining area back, the rectum to the colon, or they sew the colon to the anus. They make a stoma. So from the rectum to the outside of the body, this is so waste can come out. This procedure is done if the cancer is too close to the anus. It's called a colostomy. They put the bag. Sometimes, like I said, it can be reversed unless the entire rectum is removed. Then it's permanent at that point. So for prostate, the main type of surgery for prostate cancer is a radical prostatectomy. This is where the surgeon removes the entire prostate gland and the tissues around it, including the seminal vesicles. It's done in several ways. So open approach is going to be the more traditional approach, is where the surgeon operates through a single long incision to remove the prostate and the nearby tissues. It's called an open approach. They don't do it as much as they used to. And then there's two ways to do it: radical retropubic prostatectomy or radical perineal prostatectomy. I just want you guys to be aware of all these things, even though I can't pronounce some of them, so that you're aware. So radical retropubic prostatectomy. So for this operation, the surgeon is going to make an incision in the lower abdomen from the belly button down to the pubic bone. The patient is under general anesthesia or either spinal or epidural with sedation. There is a reasonable chance the cancer, if the cancer spread to the nearby lymph nodes based on the PSA levels, the surgeon may also remove some of these lymph nodes while they're doing the surgery. The nodes are sent to the lab to see if there's any cancer cells in them. If it's done and the cancer cells are found in any of the nodes, then the surgeon might not continue with the surgery because it's unlikely that the cancer can be cured with surgery, and removing the prostate is going to lead to serious side effects. So after the surgery now, while under the anesthesia, they put a catheter in to help drain the bladder, and it usually stays in place for 1 to 2 weeks while healing. So at that point, what we have to do as nurses is keep an eye on any possible infection. So in this operation, the surgeon makes a cut in the skin between the anus and the scrotum, perineum. And this approach is used less often because it may lead to erectile problems and because of nearby lymph nodes cannot be removed. So it may also be used if other medical conditions make a retropubic surgery difficult, or the perineal operation takes less time with retropubic operation, and it may result in less pain and also an easier recovery afterwards. And they're showing you here where they're going to cut. So transurethral resection of the prostate, or TURP. You guys have probably heard of TURP before. This is going to be an operation. It's more often used to treat men with non-cancerous enlargement of the prostate called BPH, but also for men with advanced prostate cancer to help relieve urinary problems. So in this operation, the surgeon removes the inner part of the prostate gland around the urethra. The skin is not cut with this surgery. They use a resectoscope, pass through the tip of the penis into the urethra to the level of the prostate. Doesn't mean it's still not painful. Once it's in place, either electricity is passed through a wire to heat it, or a laser is used to vaporize the tissue, and we use spinal anesthesia or general anesthesia. The operation is short, by half an hour. The catheter is then inserted into the bladder to just help drain the urine while the prostate heals, and the patient can leave the hospital in about a couple days, return to activities in 1 to 2 weeks. So we do the patient teaching for them. Risk of prostate surgery: reactions to the anesthesia, bleeding from the surgery, blood clots to the legs or the lungs, damage to the organs, infection at the surgery site. Rarely, part of the intestine might be injured, which could lead to infection. If lymph nodes are removed, a collection of lymph fluid called a lymphocele may need to be drained. But these are all things may not happen. Side effects of the prostate surgery: urinary incontinence. So men with stress incontinence might leak urine when they cough or laugh or sneeze. And then just explaining, stress incontinence is the most common type after prostate surgery. Men with overflow incontinence have trouble emptying their bladder. They take a longer time to urinate, and they have a dribbling stream with a very, very minimal force. Men with urge incontinence have a sudden need to urinate, but this happens when the bladder becomes too sensitive and to stretching when it fills with urine. So also side effects, erectile dysfunction, which could be impotence. So erections are controlled by two bundles of nerves on either side of the prostate. So this is known as, if the surgeon tries not to injure these, it's known as a nerve sparing approach. But if the cancer is growing very close to that area, they may have to remove it. The surgeon has to remove it. If both nerves are removed, the patient will not be able to have spontaneous erections. But if only one side is removed, then they may be able to. And then now for mastectomy, removal of the whole breast, there's 5 different types of mastectomy: simple or total, modified, radical, partial, subcutaneous. So simple or total is the breast tissue itself. So the surgeon removes the entire breast. The surgeon does not perform axillary lymph node dissection. However, sometimes the lymph nodes are occasionally removed because they happen to be located within the breast tissue that's taken during the surgery. No muscles are removed from the breast. For a simple or total mastectomy, it's appropriate for a woman that has multiple or large areas of ductal carcinoma in situ. So for women seeking prophylactic mastectomies, that is when they remove the breast, just because they're afraid that they might get breast cancer, simple or total. A modified radical mastectomy involves removal of both breast tissue and the lymph nodes. Surgeon removes the entire breast. The axillary lymph node dissection is performed, during which levels 1 and 2 of underarm lymph nodes are also removed. No muscles are removed. People with invasive breast cancer who decide to have the mastectomy is going to receive a modified radical mastectomy, just so the lymph nodes are also examined. And then examining the lymph nodes is going to identify if the cancer has spread beyond the breast. So the radical is the most extensive type of mastectomy. The surgeon removes the entire breast. Levels 1, 2, 3 of the underarm lymph nodes are removed. They remove the chest wall muscles under the breast. Today, a radical mastectomy is recommended only when the breast cancer has spread to the chest muscles under the breast. Otherwise, you leave it alone. Although common in the past, radical mastectomy, is now rarely performed, because in most cases, modified radical mastectomy is proven to be just as effective and less disfiguring. Remember, you're taking care of someone, you're altering their body, so you're trying to still keep in mind with Maslow's and what we're trying to do, and think about the physical as well as the think of the physical as well as the psychosocial. For partial mastectomy is the removal of the cancerous part of the breast tissue and some normal tissue that's around it. So a lumpectomy is technically a form of partial mastectomy. More tissue is removed in a partial than a lumpectomy. And then during nipple-sparing mastectomy, all of the breast tissue is removed, but the nipple is spared or left alone. The risk factors with a mastectomy: numbness of the skin along the incision site, numbness, tenderness because the nerves were cut, extra sensitivity to touch within the area of the surgery because of the irritated nerve endings, fluid that may collect under the scar. So they should resolve themselves, but may need to be drained, with a needle by the doctor. Delayed wound healing. So during the mastectomy, the blood vessels to the breast supply or tissues are cut. So if there's not enough blood flow to the flaps of the incision, there's areas of skin that may wither and scab, and the surgeon has to trim it. Increased risk of infection. If infection happens, it's usually discovered early because you're constantly checking the area, for signs and symptoms of infection. And then scar tissue formation. So with a mastectomy alone and a mastectomy with construction or reconstruction, there's a risk for scar tissue to form and build up over time. So the scar tissue can be lumpy or painful. And there's just some pictures of what a simple, radical, and modified mastectomy looks like. And also, just to keep in mind, just for nursing's sake, you never take a blood pressure on a woman who's had a mastectomy on whatever side that happens to be. You don't do the blood pressure there. So breast tissue analysis, I don't know if that's in the notes further on. I just want to remind you guys. So breast tissue analysis includes fine needle aspiration, stereotatic biopsy, and surgical biopsy. So for the fine needle aspiration, it's an outpatient procedure. This is initiated when the mammograph or ultrasound or palpation detects a lesion. So they put in a 21 or 22 gauge syringe to withdraw the fluid or the tissue and then send it to a lab for analysis. Stereotatic biopsy is an outpatient procedure. Again, it's performed on a non-palpable lesion found in a mammogram. They send the lesion as well to a small lesion. It's clipped and it's placed at the site of the biopsy so the specific area can be visualized again when they do another mammogram. So what I was going to say is they take that small lesion sample to pathological exam to see what's going on with it. And then surgical biopsy is the most common outpatient surgical procedure. It's done with local anesthesia, conscious sedation. And this is going to be now a type of surgical biopsy, including excisional biopsy, incisional, true cut, and wire needle localization. Though those are all the types of surgical biopsies that you may or may not need to know, but you know, it's in your notes, so now you're aware of it. Okay. Excisional, known as a lumpectomy, is typically performed for any palpable breast mass. The entire lesion within a margin of tissue surrounding it is also removed. Incisional is going to be when tissue sampling alone is required to confirm a diagnosis and determine hormonal receptor status. A true cut is when the surgeon uses a special large lumen needle to remove a core of tissue when the tumor is relatively large and close to the skin's surface, when they suspect a carcinoma lesion. And then wire needle localization is a technique when mammography detects minute pinpoint calcifications, indicating a possible or potential malignancy. So for hysterectomy now, removal of the uterus can treat various medical problems for females. So during the operation, the surgeon may also remove other parts of the reproductive system, cervix, ovaries, fallopian tubes, depending on why they're doing the hysterectomy to begin with. So after surgery, menstrual periods are going to cease. Pregnancy is not possible. Hysterectomy could be a treatment for abnormal bleeding, pelvic pain or infection, or even endometriosis. So hysterectomy can end chronic pelvic pain, pain during sex, lengthy or heavy bleeding that comes from endometriosis. And then endometriosis occurs when the lining, the endometrial cells that make up the lining of the uterus, grow outside of the uterus. They attach to other organs and bleed on a menstrual cycle. So conditions were treated with hysterectomy. Adenomyosis, which is a lining of the uterus, grows in the muscle of the uterus. Pelvic organ prolapse, where the pelvic organ, bladder, urethra, vagina, rectum, or small bowel drop or prolapses from their normal place and they push against the walls of the vagina. So they prolapse. Fibroids are non-cancerous growths in the uterus. So for heavy bleeding or pelvic pain from fibroids, hysterectomy will end that, end menstruation and relieve pelvic pressure. So the surgeon may also remove the ovaries for treating the fibroid tumors. And then of course, precancerous conditions would be another reason why we do a hysterectomy. So conditions treated: cervical, uterine, or endometrial cancer, endometrial hyperplasia. So this is with a very high level of estrogen. It causes the uterus lining to become so thick and develops abnormal bleeding. And then bladder or intestinal blockages. So if the uterus or a growth is blocking the bladder or the intestine, you can treat it with a hysterectomy. The side effects are going to be: the short-term risks are mild and minimal and occur about the first 30 days after the surgery. Blood loss, risk of and the risk of blood transfusion, damage to the area, bladder, urethra, blood vessels, and nerves, blood clot in the legs or lungs, which could also happen with any surgery, infection, side effects due to the anesthesia, and the need to change the abdominal hysterectomy from one of the other techniques. So hysterectomy has a rare long-term risk of pelvic prolapse, which you just talked about what that is. Total hysterectomy, let's talk about the types. So the surgeon is going to remove the uterus and cervix, but not the ovaries. Okay, total is the most common type. Hysterectomy with oophorectomy, the surgeon removes the uterus, one or both ovary, and sometimes fallopian tube. Radical, the surgeon removes uterus, cervix, top portion of the vagina, most of the tissue that surrounds the cervix, and even sometimes the pelvic lymph nodes. This is really for cancer treatment. And then supracervical, the surgeon removes the body of the uterus, leaves the cervix intact. Here are some pictures. Again, I love to show pictures to my visual learners. Partial, total, removal of ovaries and fallopian tubes, so you're aware of what they are. And then uterine surgery. So we have a urostomy is the most common type of urinary diversion operation. The doctor makes a hole in the abdominal wall known as a stoma. A small part of the small bowel is removed and connected to the ureters. The other end is connected to the stoma. A flat waterproof pouch is now connected to the stoma. That's going to collect the urine. So, and I have pictures of that too. Continent urinary diversion, similar to urostomy, except not required to use a pouch. So a section of that bowel is going to be used to create an internal pouch in where the patient has to put a catheter in to drain the urine out. So it's inside. The pouch is connected to a ureter at one end and to a stoma at the other end. So it's not outside, it's inside. Bladder reconstruction, in some cases they can create a new bladder known as a neobladder. This is done by removing a part of the bowel and reconstructing it to a balloon-like sac before connecting it to the urethra at one end and the ureters at the other end. So two main types of urostomies are available: ileal conduit. So to create an ileal conduit, the surgeon takes a short segment of the small intestine, reconnects it to the remaining intestine so it functions normally, and on one end of the removed short segment of the intestine is placed at the skin to create that stoma. The ureters, which we know carries urine from the kidneys to the bladder, are then attached to the other end of the segment of that intestine. Urine is now going to travel through that newly formed ileal conduit and the stoma that goes into an external collecting pouch. This pouch is an outlet for releasing urine into the toilet without removing it from the stoma, so they can get rid of the urine that way. Here's a picture. Urostomy, very rare. Surgeon connects the ureters directly to the abdominal wall to create a stoma. Like the ileal conduit, the ureterostomy requires a collecting pouch placed over the stoma because there's no muscles around that stoma to control the flow of urine. So after surgery, a wound, ostomy, and continence WOC nurse can provide teaching about the caring for urinary diversion. For an ileal conduit or ureterostomy, the pouching system has two parts: a barrier that sticks to the skin, which we have to maintain and make sure it's clean and make sure the area is dry and there's nothing coming and leaking out there to cause any breakdown. There's a pouch that attaches to the barrier, and in some systems it's a whole unit. I've seen usually where it's parts. I haven't seen it as a whole unit. Actually, I think I have seen a whole unit before, but usually it's parts. You cut, you stick, you make sure the air is clean and dry. You don't want your patient to have any skin breakdown. And then urinary surgery. So for a pouch, clean skin with wet towelette. So this is what you do with a wet towelette. Changing the pouch, you let the skin dry completely before applying the new pouch. If the skin is irritated, use protective skin wipes or an ostomy powder just specific for that, not just any old powder. For a continent diversion, you're going to irrigate or flush out the reservoir using sterile water or normal saline and a syringe. Since the reservoir is made from a part of the intestine, it might produce a mucus, but that is normal because it's part of the digestive tract. So irritating or flushing the reservoir will clear the mucus from the reservoir. Urostomies and continent urinary diversions can get infected. Symptoms would be dark urine, urine with excessive mucus, strong smell in urine, pain in the back, poor appetite, nausea, and vomiting. So make sure and look out for these from your patients. And I had to put a picture in here for you guys so that you're aware of what the types of urinary diversions look like. Even though, like I said, I can't pronounce most of them, at least you know what they look like, where they are, where the pouch is, and what they do. Okay, on something else now, laryngeal cancer. So this is going to be malignant cancer cells that form in the larynx. Most occur in the squamous cells, which are, inside your larynx. A person has a greater risk if they smoke or use tobacco. Some of the following may be symptoms: a sore throat or a cough, doesn't go away; change in the voice, hoarseness, doesn't get better; pain or trouble when they swallow, air pain; lump in the neck or the throat; and dysphonia, which is problems producing voice sounds. So for any of these symptoms, dyspnea, stridor, globus sensation, hemoptysis, see the physician right away. Let the patients know if these start to happen to you, you got to get to the doctor. In laryngeal cancer, depends on the part of the larynx that's affected and where the cancer has invaded. Cancer that begins in the larynx can spread to other parts of the body through the bloodstream or the lymph nodes. Lymph, as we know, clear, yellowish. It removes bacteria and proteins from the tissues. Lymph nodes, are bean-shaped. Clusters are found in the neck, the armpits, the abdomen, the groin, chest, arms, or even legs. Laryngeal cancers are grouped by early, advanced cancer. In early laryngeal cancer, 0, 1, and 2, the tumor is small, the cancer remains in the larynx. For advanced stages 3 and 4, it's larger and it's affected now the vocal cords or even invade the lymph nodes and other parts of the body. So laryngeal cancer, you treat that with radiation, chemo, surgery, sometimes a combination of all of those, okay? Oh my gosh, I don't know what it's doing. Ooh, it just blanked out there. Okay, so, and there's just examples of, let me go back. With radiation, radiation therapy delivers high energy rays to kill the cancer. Chemotherapy uses medication to kill or slow the growth of rapidly multiplying cancer cells, IV or pill. And then surgery for this cancer is done. We want to let the patient keep major function of the larynx, so speaking and swallowing. We want to take that cancer out without having to remove the entire larynx. So surgery for early laryngeal cancer would be to cure the cancer while keeping the normal functions. Surgeries performed for early laryngeal cancer: chordectomy, removal of a vocal cord; a vertical partial laryngectomy, removal of part of the larynx and vocal cord; frontolateral hemolaryngectomy, which is removal of part of the front of the larynx; supracoracoid laryngectomy, removal of most of the larynx while you save the voice; and then supraglottic laryngectomy, removal of the supraglottis. So surgery may include total, where we remove the larynx, vocal cords. This is stage 3 and 4 cancers are treated with that procedure. Neck dissection, sometimes for advanced case of cancer. The goal of this is to remove the lymph nodes in the neck where the cancer has spread. Tracheotomy, which is we put a hole in the neck below the larynx directly to the trachea or the windpipe to help the patient breathe. And this may be temporarily necessary after surgery or permanent, just depending on the size of the tumor. Okay, that is the last one for this. Now we're going to talk about some medications. Get back to my slide. Okay. So here we are now with medications. So some types of meds that we use in the care and treatment of patients that have abnormal cellular growth, and these are a list of them. So I'm going to go over the notes for it. For chemotherapy, and we've gone over some of these in class. It's not very long, but I just want to put a separate PowerPoint for you guys on the different meds. So for chemo, this is the use of any drug to treat any disease, but for most people, chemo, they think about with cancer treatment, so they call it chemo. So surgery and radiation therapy to remove, to kill, or to damage these cancer cells in a specific area, but chemo, you know, can work throughout the whole body. So chemo means we're going to kill these cancer cells that have metastasized to other parts of the body away from where it initially started. There are three main goals for chemo: cure, control, and palliation. So for cure, if possible, chemo is used to cure the cancer, meaning the cancer is destroyed. Most doctors don't really use the word cure except as a possibility. So when they're giving treatment, they might say it's treatment with a curative intent because they can't use the wrong words. So though cure may be the goal, it doesn't always work out that way. So if, you know, depending on what's going on with the cancer, where it is, how much it's metastasized, you know, it takes often many years to know if a person's cancer is really cured. They go into remission. For control, if cure is not possible, now we want to just control the disease. So chemo is used to shrink the tumor, stop the cancer from growing or spreading. In many cases, the cancer doesn't completely go away, but it is controlled and it's managed as a chronic disease, much like for heart disease or diabetes. So it doesn't go away, but it's maintained. So chemo then can be given, but the cancer is expected to come back. Okay, they're controlling it. And for palliation, this is also to ease symptoms like, you know, palliative, called palliative chemo or palliation. This is when cancer is at the advanced stage. It's not under control. It's spread from where it was to other parts of the body. The goal is to just help with quality of life. Okay. So for example, anti-nausea treatments or pain meds are palliative. It can be used throughout different stages of treatment, but when we teach about palliation and hospice, it's really about keeping the patient comfortable, managing the signs and symptoms, because it's not going to cure the disease. It's just going to make them comfortable while they have it. So doctors will take into the following factors into account when they're being treated with chemo: the type of cancer, the stage, the age, the overall health of the patient, serious health problems, and if they've had any treatments in the past for cancer. So most chemotherapy drugs, strong medications, fairly narrow range for dose safety and effectiveness. Too little of the drug is not going to treat the cancer. Too much is going to be life-threatening. So it's very closely calculated, very precisely. Depending on the type of drugs, there are different ways to determine the chemo doses. Most are measured in milligrams. The overall dose is based on a person's body weight in kilograms. And then, for example, if the standard dose of a drug is 10 milligrams per kilogram, the person weighs 110 pounds, just 50 kilograms, you get 500 milligrams because you multiply 10 by the 50. So some chemo doses are based on body surface area, which is BSA, which is calculated using height and weight, and they give you meters squared, and they usually will give you like a nomogram or something that shows you where the line will cross. That's usually given to you. You don't have to memorize any of that. So because children's bodies process the drugs differently, and also elderly, the doses for children and adults are going to differ even after BSA is taken into account. So for the same reasons we adjust for people who are elderly, who have a poor nutritional status, are obese, they're taking other medications, they have already had or are currently getting radiation, they have a low blood cell count, they have liver or kidney disease. That's always going to affect how we calculate the dosages depending on all these different vulnerable populations or special populations. So chemotherapy is commonly given at regular intervals called cycles. A cycle may be a dose of one or more drugs followed by weeks without the treatment, so the body can kind of recoup and then they get back on it again. This gives the body some time, the cells some time to recover from the side effects. It's affecting everything. So sometimes doses may be given a certain number of days in a row or every other day for several weeks. Then they rest. And then some drugs can work really well when they're given continuously over a set amount of days. But each drug is given on a schedule to make the most of its anti-cancer actions and to minimize the side effects. They're going to have side effects. If more than one drug is used, the treatment plan is going to say how often and exactly how much drug is going to be given at each cycle. So the number of cycles given is decided before the treatment starts based on the type and the stage of that cancer. In some cases, the number can be flexible because when we're treating that patient, we don't know how they're going to react, how their body's going to respond. So we look to see how they're doing, and depending on how their health is and how it's affecting them, that's how we're going to give the medication. For steroids, steroids are used as a part of cancer treatment to help with the side effects of the treatment. So these are substances our body makes naturally. They control different functions in our body, the immune system, the way we use food, how we reduce inflammation. Steroids like prednisone and Solu-Medrol, hydrocortisone are used for cancer treatment. They can also be man-made as part of cancer treatment. So steroids are taken as tablets or liquids by mouth or injection. They cause side effects, which can be different for each person depending on the dose that is given. So we have the most common side effects: stomach pain, raised blood sugar, we know that it increases the glucose level, buildup of fluid, increased appetite, and mood changes. So these are the common side effects that will happen. For analgesics, if the pain is from the cancer itself, it can be from either the cancer is growing or it's destroying nearby tissue. As a tumor grows, it presses on nerves, bones, and organs. It also can release chemicals that will make the patient have pain. So treatment for the cancer can help the pain in these situations. However, cancer treatments include surgery, radiation, and chemo. They will also cause pain. So while you're trying to help the patient, other things are causing pain. So they could do over-the-counter medications, ibuprofen, acetaminophen. They can do weak opioids like codeine, even strong opioids, morphine, oxycodone, hydromorphone. So just depending on the level, based on the scale, what the patient says the pain is, and the WHO pain ladder, you give the medications accordingly. One of the most common side effects for opioids is constipation. We already know that. We always will make sure the doctor has prescribed stool softeners, maybe laxatives. It's very important to prevent it, then try to treat it. So other issues could be nausea, vomiting, and drowsiness, which we know will be caused by the analgesics, but it goes away after a few days. And then other pain medications. So common over-the-counter pain relievers may damage the kidneys, cause ulcers, or even increase the blood pressure. But we have to weigh the risk and the cost, and benefits with the patient. Yeah, we're going to have issues of constipation. We might have some liver damage if they take too much of it. But what are we trying to take care of right now? So we have to think about that as well. Hormone therapy is used to also treat cancer because it lessens the chance that cancer is going to return or stop or slow its growth, easing the cancer symptoms. So hormone therapy is used to reduce or prevent symptoms in men with prostate cancer who cannot have surgery, for example. So hormone therapy falls into two groups: those that block the body's ability to produce the hormone, and those that interfere with how the hormones are going to behave in the body. So hormone therapy to treat prostate and breast cancer that use hormones to grow. And hormone therapy is most often used along with cancer treatment. So the type of treatment that's needed depends on the type of cancer. If it's spread, how far it's gone. If it uses hormones to grow, then you want to interrupt it. Also, there's other problems. So when used with other treatments, hormone therapy can make a tumor smaller before surgery. It's called neoadjuvant therapy. It can lower the risk that the cancer is going to come back, called adjuvant therapy. It can destroy cancer cells that have either returned or spread to other parts of the body. So because hormone therapy blocks the body's ability to produce hormones, it causes side effects, of course. So the side effects are going to depend on the type of hormone therapy and how the body responds to it. People respond differently to the same treatment. We don't always get all the same side effects. Every patient is going to be different based on male, based on female, based on genetics. They're all going to respond differently. So some common side effects for men who receive hormone therapy for prostate cancer: hot flashes, loss or interest of ability to have sex, weakened bones, diarrhea, nausea, enlarged or tender breasts, and fatigue. Some side effects for women who receive hormone therapy for breast cancer, very similar, except for vaginal dryness, change in menstrual cycle if no menopause, and mood changes. All the rest are the same between both of them. So hormone therapy may be given in many ways. They can be oral, they can be injection, and they can be surgery, okay? Where we remove organs that produce the hormone. If they're taking hormone therapy for prostate cancer, regular PSA tests are going to be conducted. If they're taking hormone therapy for breast cancer, regular checkups are scheduled. We're teaching the woman how to also do her own breast exam. Regular mammograms, imaging procedures, lab tests are also important. For BRMs, these are called biological response modifiers, and these are compounds that are used to treat cancer by changing or adding to the naturally occurring processes in the body. So immunotherapy makes use of BRMs to enhance activity of immune system, to increase our body's natural defense mechanisms against the cancer. When an immune cell recognizes an object as a foreign object or infected, a cascade of things are going to happen, which leads to the destruction, removal of this targeted object. So we call cytokines. Cytokines are secreted proteins produced by cells of the immune system that allows communication between and within the cell types. The role of cytokines in the body's defenses make them appealing targets for treating these cancers. The most frequently used to treat cancers are interleukin-2 and alpha interferon. I just put this information here so you guys are aware of what they are. It gets very biological here, but I just want you guys to be aware of what these do. So IL-2 is used to treat metastatic kidney cancer and metastatic melanoma. It's administered into a vein, IV. It's combined with other drugs. It's also been investigated for used to treat some lymphomas and leukemias. Interleukin-2, IL-2, it's a naturally occurring protein that's made by your body in small amounts. And this drug, they have Proleukin, which is man-made, but it works by activating cells of the immune system to attack and kill the cancer cells. It has side effects: nausea, vomiting, diarrhea, loss of appetite, sores in the mouth and throat, tiredness, weakness, and dizziness. So now, like I said again, the patient have to think about, can I deal with these side effects versus, helping to take care of the cancer that I have. So patients need to have normal heart, cardiac rhythm, pulmonary function. They do a thallium stress test for that just to see if they can even get this. Alpha interferon is given in a two-step process. In the first step, which is called induction, they give the drug through IV. In the second step, it's given as injections under the skin, in the abdomen or the thigh. It's used to treat kidney tumors, melanoma, multiple myeloma, carcinoid tumors, and some types of lymphoma and leukemia. It's a naturally occurring protein, like I said, occurs in small amounts. The side effects can be somewhat severe, like flu-like. However, these issues typically occur after treatment and decrease when they keep using the treatment. So contraindication: interferon can worsen existing heart, liver, kidney, and mental health problems. So all of this needs to be indicated before the patient uses it. The cytokines now, they are a large group of protein, peptides or glycoproteins secreted by these cells of the immune system. These are a category of signaling molecules. They mediate and regulate immunity, inflammation, and hematopoiesis. So for example, cytokines made by lymphocytes are referred to as lymphokines. Many of these are known as interleukins. They are not only secreted by the leukocytes, but they're able to affect cellular response of leukocytes. This is just a little bit of background about what they do. I do not believe you're going to be tested on what is a cytokine, what is an interleukin. I don't think you're going to be tested on that. I just want you guys to be aware of how they work and what they do in the body. So these are secreted by monocytes and macrophages. They're called them monokines. And chemokines they are cytokines with chemostatic activities. If you see the word, you will have recognized it. That's my goal, to make sure you recognize some of these and you're not being thrown off on an exam and you've never seen it before. Immunosuppressants, they include any method to block abnormal or excessive immune response. Immunosuppressant, they block the immune response. They include your corticosteroids, your cytotoxic drugs, your cyclosporins, your intravenous gamma globulins, monoclonal antibodies, and plasmapheresis. Corticosteroids increase the amount of neutrophils in the blood, but decrease their aggregation at the inflammatory sites. Cytotoxic drugs, they kill all WBCs and their precursors. Cyclosporins are selectively inhibit CD4 or helper cells. They're used to extensively block rejection. This is what they use for people that have transplants. Intravenous gamma globulins inhibit phagocytosis of the platelets. Monoclonal antibodies are lab-created antibodies from a single cell line that block specific cytotoxic T cells. They are being tested in the treatment of cancer and transplant rejection. And then plasmapheresis, this is going to be the separation and removal of plasma-containing autoantibodies. It's effective against disorders in which autoantibodies are tissue-specific, like myasthenia gravis. And in those where more autoantibodies are found in the blood than in the intravascular spaces. Your immunotherapy, we're almost done. The immunotherapy is a type of cancer treatment that helps the immune system fight cancer. It helps the body fight infections and other diseases. It's made up of white blood cells, organs, and tissues of the lymph system. This immunotherapy is biological therapy, which we know is a type of treatment that uses substances from us, could be ourselves, living organism, to treat cancer. There's different forms, IV, oral, topical, or intravesical, which is directly into the bladder. And then we have alpha-1 adrenergic receptor blockers. So terazosin, for example, relaxes smooth muscles of the bladder neck and the prostate, which reduces symptoms of BPH. We also have finasteride, which is your post-scar. You're not going to see brand on your exam. You're only going to see generic names. This is effective in preventing conversion of testosterone to dihydrotestosterone. This suppresses glandular activity and decreases your prostate size. And then side effects of the anti-androgen agents include gynecomastia, erectile dysfunction, and even flushing. Okay, and that is the end of that lecture. I do apologize for all the mispronunciations. I was getting tongue-tied with some of these words today. Like I said, it's been a very long day, but that's okay. I just want to make sure that you guys, even if you can't pronounce these words, it's okay. I want to make sure that you've seen them, that you're aware of it, that nothing is a surprise to you on the exam. I'm saying to you certain things may not be on the exam. I don't know 100% because I'm not able to see it. So what I'm telling you is based on writing items myself, for exams, there's certain things that you're not going to really worry about your students knowing. They're not worried about you having to memorize anything. We want to know that you can look at something and understand critically what it's asking. I know the exams lately have moved from traditional true and false or traditional multiple choice. Now they're looking at more select all that apply. Do not be afraid of select all that apply. They are not scary. What you need to do is when you read a question that says select all that apply, like I said to you, read the stem of the question. Do not look at the answers yet. Ask yourselves in your mind, what is this question really asking me? It's asking about, ALL, for example, or one of the other cancers or leukemias or heart disease. What do I know about this? If you know enough, when you start to read this, select all that apply, you'll know, yes, this does deal with it. Nope, this does not. I'll say something to you guys. The questions that are coming from select all that apply, they can either be 1, they can be all, they can be 3 out of 5. So it just depends. I don't want you to think if it's select all that apply, maybe if it's five choices, it's got to be 3 out of 5 or 4 out of 5 or 2 out of 5. No, now the questions can be all of the answers can be correct. So I just want you guys to be aware, not to scare you, but just so that you're aware. I told you guys I teach for NCLEX test prep. I know what's coming. So that's why I'm saying to you, if you see these questions, read each one very carefully. Think of select all that apply as a true and false. Is this true to what it's asking? Nope. If one word is wrong, it's false. Think of the comma rule. If there's a bunch of commas, comma, comma, comma in a sequence, and one of those commas is incorrect, the whole answer choice is incorrect. You don't get partial credit, okay? So I'll think of some more of these strategies for you guys, and as we do next week's lecture, I will let you guys know. I'm not worried about the content. You guys can get content anywhere. You guys know how to read. You can read a PowerPoint, you can read your book, you can look at videos, you can do all this stuff. My issue is once you have that information, how do you test? How do you know about using strategies to pass an exam? And that's what I want to make sure that you guys know, okay? So I'm going to spend some time next week going over that with you. Yes, I'll go over the cumulative review. Yes, I'll go over your answer choices, but I want to spend more time on your strategies for how to take your test. If you have to buy the Excelsior exam, it's $75, guys. You get a couple full-length exams. If you need to do it, just do it. That way you're prepared, you know what to look for, you know how the questions are worded, and you're not surprised. So this level, you guys aren't surprised. You're already on the 200 level classes. I just want to make sure you're successful, okay? So I'll wrap up today's class. John, thank you for attending. And I want to say it was a lot of information. I did try to condense it, but there's just so much. Do not try to memorize everything. You're not going to be tested on everything on this exam. Focus on the main key things that we talked about. Read your book. Like I said, look at the videos, do your quizzes, and if you have any questions, please email me or please send me a message on the discussion board. If there's something that I cannot answer, I will forward it to academics. Someone is going to be able to help you, okay? So with that, I'm going to wrap up for today's lecture. I will see you guys back for next week. Please make sure, as I close this off, please make sure that, let me go into next week for week 7. That you guys do, there is going to be, where is it? There is a part 1 and part 2 that says PowerPoint questions. Please do them before you look at the lecture. If you cannot attend live, that's okay. But do these questions before you watch the answers, because all I'm going to do at the beginning or maybe at the end, I don't know, is I'll give you guys the answers and we're going to go over the cumulative review. I might not read every single thing. These are all slides from the previous weeks we've done that I've pulled that I want to make sure you guys really understand. So, right, that's the goal for next week. It's going to be a little bit long, but I want you guys to get a good understanding of it, okay? So let me know if there's anything I can do to help. I want to make sure you guys are successful, and have a great rest of your week, and I'll see you guys back next week, okay? Bye-bye.